a significant conversation, this one for the School of Medicine on tribalism in academic medicine. We touched on tribalism at the first of our sessions. It's a pretty audacious topic for us to discuss and review. How assumptions and predispositions influence how we address questions, the biases of those predispositions, and how they influence our conclusions. We'll hear from a number of colleagues who focused on this in a scholarly manner throughout their career. They'll enlighten us about the history of inquiry, bias, and its impact on discovery. As I think about it, in my day-to-day life, I come to think about each of us has a worldview and how that impacts our impartiality in everything we do, including research and the questions that we ask. Science is complex enough, and it's even made more complex by each of us and the perspectives that we bring to it. It is somewhat perplexing to think of the fact that our perceptions of truths are really influenced and based on our biases and assumptions. So I hope this evening we get to rethink about all that and then take a step back and have heightened awareness about how others might do things differently than we do. I should also point out that it matters in our field because after all, what we do isn't just to discover and invent, it's also to influence humans in their health and their health decisions. We've seen innumerable examples of how facts that we thought were true weren't, and how diagnoses, therapeutic options, inventions are disrupted by new ideas. It's interesting to me that Tony Fauci, who's commonly in the news, in his concluding remarks just this week, stepping down from the NIH, said the thing he struggled with the most was how to change his information flow as new information came in, and how little people could flow with the new information the way he was able to. And perhaps couching that in terms of worldview and assumptions and biases would help even he better communicate. So I think that we should view these transitions as the norm, not as the exception, and for that reason I'm looking forward to the conversation. Thank you.
Thank you, Stan. Very helpful and nice introduction to today's session. So I'm going to go, I think I have to share screen. Okay, so I don't have many slides, and I'm not going to take you too deep into the philosophy of science, and you'll all be thankful for that. But I do want to underscore a couple of real basic points, really one, about our topic today. I want to rehearse just really quickly, without reading for you, what precipitated Stan's thinking about having this series. And it was an interview about a year ago with Francis Collins that was on public radio, where he kind of confessed that, geez, we're so fragmented, we're hyperpartisan, we're overpolarized, and we didn't anticipate, we scientists, we docs, we public health folks, what people, how people would respond to the measures we proposed, and just how partisan and polarized the climate was, even in the face of a life-threatening disease. What the heck, right? And he's very concerned about it. And one of his take-homes is, boy, there are things about human behavior that I don't think we've invested enough into understanding. And now, maybe not NIH, but others have, and we have a long way to go. We're learning, but we are learning. And he's right. Human behavior matters if you're going to translate, the science, the good public health, the good clinical practice into people's lives, right? You got to know what creatures like us are actually like and what uptake's going to look like, right? So that comment underscored, reiterated, Dean Gerson's like, let's try this. Okay, so the first one is, what's tribalism? What are some of its benefits? What's in-group, out-group, some of its benefits, some of its burdens? How does it affect the way we look at the world and interact with one another and categorize and dice and slice and so on. Today, it's really how do these frames we carry, that many of which we're completely unaware of or nearly completely unaware of, impact science, our methods, how we teach, how we deliver healthcare, right? I'm going to take us into a little tiny bit of philosophy of science. What's this a picture of? Two pictures. What's here? It's the Ptolemaic world, right? Copernican world. Look how different those are. The Ptolemaic world, at the time the Copernican world emerged, was far more explanatory from a scientific perspective, more powerful, accounted better for the data. Turned out the Copernican world was more accurate, at least as we came to see the data later. But what drove the change? At the time, as Thomas Kuhn, and nobody's really knocked this down very well, and I don't think he can, as Thomas Kuhn showed us, paradigm shifts in science, what we call revolutions, right? They're driven more by social and political forces than by data. So the Copernican, Newtonian, and Einsteinian revolutions, which are profound and important, but they were driven first, and maybe even primarily, certainly at the outset anyway, by social and political forces. So how might we think about this? Well, we can translate Kuhn a little bit to our world here. We can say, well, Kuhn's insight, we take it and we extend it to other areas like academic medicine, is to say that social and political values or deep value-laden considerations impact and inform our deepest paradigms that underlie what? The biomedical model. Jonathan Sadowski is going to talk about that. Basic science research, Dr. Fortenberry. Clinical science research, Dr. Farrell. Medical education, Dr. Wilson Delphus, and clinical care, Dr. McNamara. And Dr. Sadowski is also a doctor, just a historian. And you count too. So with that, I want to turn things over to Dr. Sadowski.
Okay, I want to start with a couple of things, actually, a few things that I actually hadn't planned that weren't part of what I prepared for today, but came to me over the course of the day as things unfolded. So the first thing, as I was looking at Mark's slides and thinking about Francis Collins's remarks, one reaction I had that may be helpful, may be able to help people see what the distinctive contribution of history in my field is to say that a lot of this is not as new as it might seem. In fact, most of this is very old. And one of the benefits of, I always tell students, I try at the beginning of the semester to get them to think about why actually should we study history? Why is that important? And I always tell them, I break them into small groups and I said, there's one rule here. You can't say because history repeats itself and then I ask them why not. And I ask them to think about why you can't say that. And the reason I don't let them say that is because it's a cliche, and cliche is the enemy of thought. And, but I do add, if you can say it, there's an exception to the rule, which is that you can say it if you can give an actual example of history repeating itself. So, so as I was looking at the remarks of Dr. Collins, a few things came to mind. One was that a dissertation student of mine who finished a couple of years ago worked on a quarantine that took place in New York City on Staten Island in the 19th century. And she was studying this quarantine and looking at it from various points of view. There was one really interesting finding in her research that stayed with me, which was that there were people in favor of the quarantine and people against the quarantine, but How did they line up? Actually, what were the reasons that they lined up on one side or the other? And what she found was that they lined up behind leaders. That is, it had nothing to do with their pre-existing scientific or social disposition. It was the leaders of the anti-quarantine and the leaders of the pro-quarantine movement. And then their followers just took that as the right position. Does that sound familiar? Second example. In the 19th century, in Naples, Italy, much of the world was dealing in the 19th century, as you may know, with cholera epidemics. Cholera was being widely spread largely as a result of the British Empire because it was so big, and cholera actually probably originated in what's now the Southeast Asia, India area, and they had a heavy presence there, and they had ships, etc. So it was going all over the world. So where am I going to get to Naples already? You want to hear about Naples? Right, okay. So here's the thing that happened in Naples. So the public health authorities put up signs warning against fruit, being careful with fruit, making sure it's clean, making sure it's not rotting. And they were no doubt very well intentioned, right? And but not everybody saw it that way. One of the things that happened in Naples was that some of the populists started not only defiantly eating fruit, but having public flagrant demonstrations of fruit eating. Does this sound familiar? I know it's a little different. When I say it repeating, I'm not saying it's the exact same thing. I'm saying it's similar enough, right? And in fact, I could go on and on. I've been, as you might imagine, I've been teaching quite a lot about the history of epidemics over the last few years, and I could give you more examples of this kind of repetition. But what I'm trying to show with these two examples is, if you want to call it tribalism, it's not new, and so we need to think about that. Actually poses a challenge to us, in my opinion. It poses a challenge of how do we actually break it? I mean, is it so deeply embedded in human behavior that there's nothing we can do about it? I like to think not. I like to think that actually by studying these examples and seeing the precedents, that we might interrupt these cycles. So I have one last thing that I want to, this is still not from my prepared remarks. But earlier today, my colleague Eileen Anderson and I were teaching Foundations of Medicine, Society, and Culture, which is the core course for the Medicine, Society, and Culture track within the bioethics master's degree program. And we had them read a classic text, 19th century text, The Yellow Wallpaper by Charlotte Perkins Gilman. Quick show of hands, how many of you have read it? Well, what are you waiting for? Do yourself a favor tonight. Go home, read it. You can read it in a night. It's a little novella. It's great. It's classic. Okay. And anyone who's engaged with medicine at all ought to read The Yellow Wallpaper. I use it in a lot of my courses. So what is The Yellow Wallpaper about? The Yellow Wallpaper is the story of a woman suffering from some kind of mental disturbance. It's, hard to say from our point of view exactly what. In those days, common diagnoses were neurasthenia, hysteria. Nowadays, we might be inclined to think it was possibly depression. I don't know. I don't think the important thing about the novella is exactly figuring out what she had. It's a fictional story anyway, but it's a fictional story about something real. What it's about is about what was known in the 19th century as the rest cure. And this was promoted by one of the leading neurologists in America, Silas Weir Mitchell. And it basically confined the patient to a room where she was deprived of stimulus. She wasn't supposed to read. She wasn't supposed to write. She wasn't supposed to do anything that might damage her already frail nerves. Are you thinking this might be a little bit sexist? I did use the female pronoun deliberately because a student was presenting on this in class today, and he pointed out that this rest cure, which was supposed to replenish the nerves, there was actually something quite different for men, which was called the West cure. And that involved vigorous physical activity as opposed to rest, and journaling as opposed to avoidance of intellectual activity. Now, I know we all can look at this and see that this is where the sexism is very manifest to us, right? This is an example of what Professor Elizio was talking about how background assumptions make certain things seem plausible, right? We can look back now because we have and see this as fallacious because we have a different set of background assumptions about gender, I hope. I mean, I should say, I mean, who knows? But I hope we do. And so this made perfect sense. And the reason I really focused on this was because the student, I thought, very thoughtfully made the point that Silas Weir Mitchell probably was acting from his point of view in perfectly good faith. He thought he was doing the right thing. He was helping people. It was just so self-evident to him and part of his common sense that men and women have different nervous systems. The women's is fragile, the man's is not, and that's why that you have this vigorous form of treatment for the men and this very dainty one for the women. So now, of course, the lesson of this is that this was late 19th century, maybe 140 years, 120, 140 years ago. So 100 years from now, 150 years from now, people are going to look at us and they're going to say, well, they were unable to see past their background assumptions. But maybe we can figure out ways. I'm not sure I know what exactly the way is, but this is part of an ongoing conversation. So I'm going to talk about, I don't know, the reason I keep separating between my prepared remarks and not prepared remarks is because I don't know what you saw in any publicity. So if you're wondering when I'm going to get to the things that I said I was going to get to, now's the time. I'm getting to them at last. So I want to start first. I have two examples in mind that I want to talk about. So, in introducing me, Professor Elizio talked about biomedicine. And that's something I could talk a lot about. Actually, I'm working on this. My current research involves this very deeply. And if you want, during the Q&A, I can talk about what I mean by biomedicine and how it's a culture and what its framing assumptions are. That's not what actually I prepared. I want to talk a little bit about race and how that works in medicine. So, and in particular, I want to talk about the very stubborn idea, which has been subject to over 100 years of critique now, that race has a genotypical reality. I want to be very careful about what I'm saying and what I'm meaning here. Race has a reality. Race is a real thing. It's real because it's been created socially and historically, and that's what gives it its reality. And in turn, it has biological effects because of racism and the legacies of racism and discrimination and so forth. So it has biological effects, but it doesn't have a corresponding genotypical reality. It is, as our former colleague Atwood Gaines used to say, something that came from what he called folk biology that informed formal science and became part of the common sense background. So is this still with us? I think it is. I did see just a couple of months ago reported on social media, maybe not, I don't know if it's fully reliable, but a case of an attending taking residents on rounds and referring to the old myth that Black people feel less pain. And but I'm gonna, since that's not an example, that's of course fallacious, but that's since that's not an example I can document perfectly well, I'm going to give you an example that I can document perfectly well, which has to do with a drug called Bidil. Is this familiar to anybody? So this was a blood pressure drug that was developed, and it was really, there wasn't really anything particularly innovative about it because it was derived from two blood pressure drugs that were already known to work in all populations. And the company, I forget the name of the company, the company, but I can provide a source if anybody wants. The company that was developing this drug wanted to market it as a race-specific drug. That is, they wanted to make it a drug specifically for Black Americans. And so they did a trial on Black Americans. And of course, the results were good. Why wouldn't it be? It was made from two drugs that were already known to work in anyone. But this background belief of the reality of race gave this a kind of surface plausibility, enough surface plausibility that the FDA in turn approved it as a race-specific drug. Okay, so I teach a course on race and medicine, and we deal with many of these kinds of issues. I'm going to make a plug actually right here, right now, which is that in the spring, a great scholar who works on this named Rana Hogarth, who wrote a book called Medicalizing Blackness, which shows the origins of this kinds of thinking in the early Atlantic world and the settlement of the New World and the development of the systems of slavery and plantation slavery, shows the origins of this. And she's going to be speaking here early next semester as a guest of the Dittrich Museum. I'm going to turn to my other example, which has to do with depression, which I published a book about 2 years ago. And I am a historian of psychiatry. That's my specialty. And this is something I've been working on my entire career. And when I got here to Case Western Reserve University in the early 1990s, as an early career scholar, I think it was safe to say that a really at that time, fairly significant problem in psychiatry was biological determinism or biological reductionism. Reductionism is really the word I want more than determinism. What I mean by that really is the idea that mental illnesses are, in essence, really bodily problems. These are biological problems. Now, I certainly would never say there's no biology to any mental illness. I think that's completely wrong. But we also know there's very robust data that show that social circumstances and life events also contribute. And we also know there's very substantial data that show that purely biological approaches, which are normally mostly in the forms of drugs, medicines, there are other ones like electroconvulsive therapy, but what we know, the data again are fairly robust, that these interventions are more effective when paired with social interventions like psychotherapy, for example. This does not actually seem very complicated to me, and vice versa, by the way, too. We also know that psychotherapy can be more effective if paired with antidepressant drugs. So I think what was in danger of being lost in the sort of excitement about biopsychiatry in the 1990s was the social dimension. And it was up to people like me, that is historians and other people who study the social world, to try to bring back the social and the psychological into the picture. But I don't really think that's necessarily all that plagues us now. I think in many ways, psychiatric science has progressed over the last 30 years and has taken more account of the social and the psychological, sort of bringing back in ideas that were common, say, in the mid-20th century, before the excitement over biopsychiatry really took hold in the late 20th century. But what strikes me is how, and here I refer again back to this idea of background assumptions, what we take to be common sense. What strikes me now, in the current state of things, is not necessarily so much that psychiatry itself is reductionist, but the assumption on all sides, on many sides of the debate, that we have to choose. That is, that we have to choose whether to think about these things in social and psychological ways or biological ways. Now, if you don't believe me, I'm going to try to produce some evidence now. A couple of months ago, a psychiatrist named Joanna Moncrief, author of a book called The Chemical Cure, which is a scathing critique of drug treatment in psychiatry. It's not a bad book. I disagree with some of its conclusions, but it's not a bad book. So she and colleagues published an article that showed, I think convincingly, that the idea that low serotonin causes depression doesn't hold up, because there's no one's been able to show any correspondence. That is, you can have people with low serotonin levels who are not clinically depressed. You can have people with high serotonin levels who are not clinically depressed. Am I making sense? I think I got a little jumbled there for a minute. It just doesn't correlate, right? No one's been able to show a correlation. So it's not that finding actually that troubled me about the publication of this article. What troubled me was that the conclusion then was depression isn't caused by biological factors at all. It's caused by social factors. Now you might think, okay, you're a historian, you're all for social factors. Why don't you like this? I don't like it because it's being framed as an either or. Again, we have so much data to show that depression is a complex illness, that it involves social forces, it involves life events, psychological factors, and inevitably has a biology. That seems to me overwhelmingly persuasive. What I don't understand is why so many people, and you want to see an enactment on this. I don't know if any of you use Twitter, but if you go on mental health Twitter, you can see this debate happening every single day. Is it social or is it biological? Why is it so hard for people to think that the social, the psychological, and the biological interact? I don't know the answer. It's driving me bonkers. That's all I have to say.
Why don't you come down and I'll have you come at the end. Okay? Thank you. I'm going to have a panel just for the sake of introduction, my name is Cynthia Kabu. I'm serving as the Vice Dean for Faculty. And it's really nice to see this. I want to emphasize that the goal of this whole conversation series is to figure out safe spaces in which we can talk about challenging topics and all of those hidden assumptions and biases that impact all of us. And how do we start to think outside the box and respect and understand different ways of knowing. What I am pleased to do right now is to introduce our panelists. And Mark did this a little bit as well, and I just am going to go through. I'm going to start, I guess, because Amy's sitting right here, right? This is Dr. Amy Wilson-Delfa. She's a professor in the Department of Pharmacology at the School of Medicine. Next to her is Dr. Yolanda Fortenberry, who is an associate professor in the Department of Biology here at Case. Next to her is Ruth Farrell, Vice Chair of Clinical Research at the Cleveland Clinic OBGYN Institute and Women's Health Institute at the clinic. And she's also a professor of medicine, or reproductive health, I guess, right? And then finally, we have Dr. Megan McNamara. I keep McNamara. I keep stumbling over that. And it's a privilege to get to meet her. The others I've had a chance to kind of connect with. So professor of medicine at our very own VA. And they're going to be talking about different aspects of how these implicit assumptions and these ideas can interface with and impact the work we do in academic medicine. Specifically, I think we're going to start with bench science, clinical research, then we'll go on to clinical and then pedagogy and education, if that's all right. Okay, so please, Yolanda, come on up and I am going to be a strict time master.
Oh.
So, and I warned everybody, I'm not going to be rude, I'm just being attentive.
So I'm definitely not going to take my 5 minutes because I want to get feedback from the audience. And I had comments to say, and then as I listened, it changed. So I do basic science, and I do basic science on sickle cell disease. And so now we're going to get back to sickle cell disease and race and all that stuff. Once I tell you about my class, I teach a class on biology of blood diseases and blood disorders. And I tell my students, I say, this is what happens in general terms, and it changes all the time. Now, why does it change? Because we have social pressures to change it. And our focus on political, which someone says the political and the social needs change. So recently, everyone on basic science or clinical science have been talking about COVID. Why? Because that's what's happening right now. That's what's driving our research. That's what's driving our basic research and our clinical research. So, and then we'll come back to stuff that was important before COVID came ahead that we were focusing on. So one of what I do is I work on sickle cell disease, and I do it in basic science. We work on basic therapeutics of sickle cell disease. And there's biases all over with publications, because you only publish positive data and not negative data, and negative data, which someone else telling you that is negative data. So there's bias in that sense. So there's a ton of data that's not being published because no one's going to publish negative data. Another thing that struck me when I was listening is that to understand race, the biases of individuals that come in with sickle cell disease and pain. So there's two things that radiated with me. And I study sickle cell disease, and I've been at both the basic science and the clinical department. I came here from Johns Hopkins. And one of the big things is that individuals who have sickle cell disease, they come with pain crises, they come to the clinic. And the physicians have this bias that these individuals are coming in just to get drugs. So they're drug seekers. So that's one of the things I think that we should think about and we should talk about. So they have to come into the emergency room in pain, but dressed up like they're not in pain. They have to do that. So understand, and I teach my students this. So we not only have this basic science and this publication bias, and we have to publish certain things, and we study certain things, which is all geared by what you can get funded. So there's a bias in science to begin with. So I want us to talk about a couple of those things. I know my time is probably up, but just to think about these things. I have more time. Well, I'm finished. So think about these things so I can have the audience ask more questions, and then think about these things, because these biases are all over in our idea of what people are, what they look like, or what they should study is innately a part of our basic science research and clinical research for that matter.
What a great set of comments. Thank you so much. I think, talking about sort of what's published and why is so important. So I'm so glad you raised that. I might take my whole 5 minutes. You know, when Cindy asked me to talk about pregnancy and inclusion of pregnant individuals in studies, I thought, great. And then when she said, you got to talk about it in 5 minutes or less, I'm like, no. And then one of my mentors told me, simple is better, especially when you talk about something that you're very passionate about. So I'm going to try and limit my comments to 3 basic themes here. Really think about that social and political forces that can affect pregnant individuals. So I'm going to start broad. I'm going to bring us in narrow and then take us out broad again, then open up the conversation with my other colleagues. So I'd like to start broad, and I want to think about science and the foundations of science and scientific progress. And we can see how the practice of science and academic medicine is built on assumptions and values, and how that reverberates in science, both now, but in the future. So what we do now affects scientific discovery going forward. And scientific progress builds on science that's come before us. So for a minute, I just want you to imagine that pyramid of evidence. We've thought about this oftentimes in either research courses or evidence-based medicine courses, where the top of this pyramid, the highest quality science is at the top, where that's those meta-analyses and those reviews. And right below that are the RCTs. And at the base of that are those observational studies. They have a value, but they have biases, they have weaknesses to them, but oftentimes it's where science starts. And oftentimes, because of certain assumptions, that where science resonates, particularly for certain populations like pregnant individuals. So it's problematic when we have those limitations to science overall, because our science is built on science with weaknesses. But when that science has weaknesses because of assumptions and biases about individuals, that's even more problematic. What happens is those individuals don't have access to high quality data about the impact of illness, disease, treatment, new diagnostics, and therapeutics. And so I want to think about this in the context of pregnant individuals, since if we don't have scientific discovery for them, we're affecting not only them, but future generations. So now I'm going to go narrow. Here's my second point, and we're going to talk about the inclusion of pregnant individuals in trials. We saw this with COVID. It was remarkable that there was this delay to science coming out about pregnant individuals. And the question is why? It was very clear what COVID was doing to pregnant individuals. They're more likely to get sick, they're more likely to be hospitalized, they're more likely to be intubated. And so we understood this. We also had data from other pandemics which affected pregnant individuals. Yet despite this, there were delays. We didn't see research, even observational research on pregnant individuals, just several months later. And the question is why? How did assumptions and biases play into that really important delay? But it's also, what are the harms, the inadvertent harms? There wasn't deliberate harm, but there was clear inadvertent harm. Over 4 million pregnant patients deliver in this country every year. And over 500,000 of those have pre-existing medical conditions. And we talk a lot about mental illness. Depression is one of those. And the question of how to use antidepressants during pregnancy was a big debate with a lot of data missing and a lot of observational trials. If we don't have research to inform patient care, then patients don't have the ability to make informed decisions about their health care. And particularly during pregnancy when they're making decisions about themselves, but also the fetus and the future child. This is bad enough, but we know that it's even worse when there are existing disparities, healthcare disparities, systemic racism, other issues that affect specific populations, and they also can't get access to healthcare during pregnancy. So it's very problematic. So where do some of these biases and assumptions come from? Ones that has to do with this idea of vulnerable. How many people in the room have heard the concept that pregnant persons are vulnerable? Yeah. Are they vulnerable? What is a vulnerable population? Let's just take a moment to think about that definition. Vulnerable population is one that has a compromised ability to protect its interests and provide informed consent. So when we think about vulnerable, that really resonates around decision-making capacity. So I asked this group, just because a person's pregnant, do they have a change in their decision-making capacity? No. So why do we consider them vulnerable? Other vulnerable populations that we think about are children. So what do you think about vulnerability with pregnant individuals? Why do we think that? And so the time has come to change that, change our assumptions and biases. The prevailing belief is that pregnant individuals are a scientifically complex population. This is the better way to describe them. It talks about the physiological, social, and ethical complexities associated with this unique state of pregnancy. And this changing state of pregnancy, so it's not just pregnant, it changes over time. Now, there may be additional considerations for how to design studies and additional protections in place, because there are important reasons to have protections in place with trials when risk is being taken. But that doesn't mean that we shouldn't do the studies. We shouldn't extend the same health care to pregnant individuals as would be given to non-pregnant individuals. And again, this became apparent during COVID. So let's talk about assumptions part 2. And I want to talk about who decides what risks are acceptable to take or to not take. when we think about research in pregnant individuals, often the discussions about the risk of an intervention. What if we do an intervention and something goes wrong? But there's a lack of consideration about what are the risks if we don't do the intervention, if we don't do the trial, if we don't have the evidence. How will then pregnant individuals make choices about their healthcare? And so this is pretty significant. Now, it raises the question of who decides what's too risky or too complicated for a trial. Is it the researchers who are translating their values and assumptions about pregnant individuals maybe being vulnerable to who should take on risks? And that's a paternalistic idea, the fact that I believe as a researcher, it's too risky for a pregnant individual to make decisions about if they want to be in this trial or not. Or is it too risky for the researcher? What if a problem happens? What if there's a fetal injury? Then what happens? So where is the risk? Is it for our patients as participants, or is it for our scientists? And again, we saw this in COVID with this great delay in even getting observational data about them. Now, what a researcher may think about risks and assumptions can translate not just to are any trials designs. We saw this, that trials were not available for COVID patients who were pregnant, but also how the trials are designed. When we think about ethics and research ethics, it's not just informed consent, it's how we design our trials. We know in science and medicine, if you don't measure it, it doesn't exist. And if your measurements for a trial are really focused on the fetus, now if your assumptions are really about the well-being of the fetus as the primary import, then you're not going to measure outcomes for the pregnant individual. And in doing so, you may ask them to take on more risks of research because you're not measuring it. If you don't measure it, you don't see it. And so that can cause significant issues as well. So again, when we think about those assumptions, it's not just what risks are too much for the fetus, but also which risks are too much for the pregnant individual. And again, thinking about the risk not just of acting, but most importantly, the risk of not acting and getting the science. And then my third point, and I'm probably almost out of time, I'm going to go broad. How do we address biases? How do we find them? We bring a diversity of perspectives to the table. As you mentioned, I'm a bioethicist as well, so I think much about ethics. And we can go to our principle of ethics to think about how do we find ways to find justice in research. But sometimes autonomy, beneficence, non-maleficence, justice just don't get us where we need to go, particularly in complex situations like pregnant individuals. We need other frameworks such as feminist ethics, those who let us see how issues of sex and gender may really affect about the opportunities that we see for research and the barriers that we see as well, and if we address it or not. But approaches like feminist ethics allow us to also look at other constructs such as race and ethnicity and see how that may also affect other populations. So we can begin to understand one lens as we see it opens up our perspectives to other populations as well. And we need these diverse perspectives to really understand and detect our biases, to understand tribalism and its effect in clinical science. Thank you.
Hi, my name is Megan McNamara, and I'm delighted to be here. Thank you for inviting me. I am going to talk about two very personal experiences that I've had, and I'll be honest that I am tribal. I didn't know I was, but apparently I am, and I'll tell you why when I reflect on these experiences. But just to set the stage, so I'm an internist. I was trained in women's health primarily, and about 7 years ago, I started taking an interest in trans healthcare. So I run the clinic for transgender veterans up at the VA, and it's been an interesting experience. So the first vignette that I want to share with you to kind of think about tribalism in its many different forms for me and my patients. I'll just read to you because I prepared this. So while I care deeply about the health and well-being of LGBTQ+ patients, not every clinician feels the same way that I do. Nurses have refused to work with my patients, and hospital staff have sometimes misgendered them deliberately. Other physicians, and this has happened quite a bit, have questioned or criticized my decision for starting patients on hormone therapy because of the perceived risks associated with treatment as compared to the perceived benefits. I actually was fired by one of my patients when she found out that I was also taking care of trans patients. And so when I encounter individuals like this, I become really mad. I become incensed. We're all here for the patients. We're all here to help people. How could some people feel this way and I feel different? And I'll be honest that I have been very black and white in my thinking. that I'm the good person and these people are the bad people for the way they feel. And reflecting upon this, especially in this venue tonight, it really does shut down conversation. It doesn't have to be all one or all the other. There's certainly a middle ground and an opportunity for us to exchange our thoughts and our feelings about this type of work. And just acknowledging that the black and white is probably where we are in this country with many transgender health issues. Obviously, it's not just particular to adults, but to pediatrics as well. So sort of reflecting on the fact that I am part of the problem, I think, and trying to be a little bit more nuanced with the people that I work with. So that's the first example. The second example is also something that I hadn't expected when I started down this career path. So many of the physicians who practice LGBTQ focused care identify as a member of the community. So many physicians who practice this medicine are LGBTQ plus or identify in some way that way. And I am cisgender and I'm heterosexual. And that has been actually a real issue for me as a physician in this practice of medicine. I always kind of feel out of step. I'm like, I'm not in the in crowd, which it's an interesting experience for me, having not really been a minority to date. And in this type of work, I am. And I'll just share a story that happened to me a couple of years ago at a national conference. So there's a very esteemed physician who I know peripherally, but I never really talked to. And I just given a lecture on LGBTQ health education in medical schools and residencies. And at the conclusion of my remarks, she came up to me and said, you know, great job, that's very interesting. In fact, I'm hosting a meeting in a couple of months in Philadelphia, and I'd like you to give that same talk to this group of academic physicians. And I said, that would be fabulous, especially since she's so prominent, and I wanted to impress her. And so I said, okay, well, just tell me what's the purpose of the meeting in general so I can make sure that I couch my remarks appropriately. And she said, well, aren't you gay? And I said, no, I'm not. And so then the invitation was actually rescinded. And, you know, for me, again, sort of very eye-opening and almost helping me identify with my patients. So A, I'm the minority. And B, because of that minority status, I was actually excluded from something I wanted to participate in. Now, it was the meeting of academic gay women in internal medicine. Obviously, that did not apply to me. So it's not like that was a wrong thing, but it was, again, another opportunity for really me to see how sort of the dichotomy, the black-white of LGBTQ plus versus not, either personally or in healthcare, can really affect patient outcomes in clinical care. So that's my own stuff.
Well, Meg, I don't know how I'm supposed to follow that. Really powerful remarks. So I'll be honest, when Mark and Cindy asked me to talk about tribalism in medical education, I really had to stop and think, what are our tribes in med ed? And to which tribes do I belong? And to which tribes do my colleagues belong? But the more I thought about it, the more obvious all of our tribes became. So what are some of these tribes? I'm going to outline a handful, and I'm sure you're going to think of even more of them that we may want to discuss during the Q&A. We have faculty teaching our students who dedicate their full-time professional lives to education. That's what they do. And we have faculty who are honestly part-time teachers because they dedicate the majority of their professional lives to basic science, clinical research, or clinical practice. Both these tribes bring different skills, they bring different backgrounds and perspectives to the enterprise of teaching. We have the basic scientist tribe and the clinician tribe, who do not always cross the boundaries from one tribe to another to most optimally train our medical students. We have the physician tribe and we have the other healthcare providers tribe. The separation of these two tribes leads to communication challenges that result in a major source of medical errors, hence the need for robust programs and collaborative practice. In the classroom at its most basic level, we have the teacher tribe and we have the student tribe. And I'm going to tell you, we do not always see the world in the same way. Students in 2022 are quite clear in their minds about how they want to learn and how they think they learn best. And as teachers, we're quite clear in how we want the students to learn and how we think they learn best. These points of view are frequently misaligned, leading to, honestly, non-productive struggle in both camps. Within the broader education community, we have tribes that focus on research and learning sciences, and we have tribes that are more focused in the classroom and dedicate effort to the scholarship of teaching and learning. The learning scientists may miss the context of learning that our teachers actually have. And our teachers may miss the conceptual or the theoretical framework that truly brings meaning and effectiveness to their chosen classroom or bedside strategies. Clearly, bringing these two tribes together would promote the determination of the most effective learning pedagogies and the design of pedagogies based on cognitive sciences and not fad. And while I've presented these tribes in pairs, they all can blend together. For many of you might be familiar with our problem-based learning in the university program here in the med school. We call it IQ, case inquiry, or IQ for short. This is a real primary form of learning for medical students in their first and second years of the program. So who are the tribes that come into play in my case inquiry example? We've got the student tribe, we've got the faculty tribe, we've got the basic scientist and clinician tribes who serve as our case authors and our facilitators. And we've also got the cognitive learning scientists, based upon whose work the IQ method was designed. Students and faculty, remember, see their surroundings and honestly people differently. As faculty, we struggle to understand now why students don't follow our recommendations about how to approach this popular learning method. And students don't understand why faculty continue to insist on things like drawing on the whiteboards, when they can much more easily download an image from any number of online resources and project it with the fabulous and expensive technology that we've provided for them in the health education campus. If we stop to think about the learning sciences tribe and how the IQ method was created, that is based on the outcomes of robust cognitive psychology research, and actually shared that information with students, maybe we could better bring all these tribes together toward the shared goal of optimal learning. And if we could bring our basic science and clinician educator tribes together and use learning strategies that have promised to promote cognitive integration of basic and clinical sciences, we would be one step closer to helping students be able to actually access and use their foundational science knowledge in the patient care setting. So I think we can bring our tribes together, and one way to do that is to bring them together to solve problems. Productive struggle is not just good for learning, it's good for breaking down the boundaries that separate us. Thank you.
Wow, I mean, I think, you know, number of themes here. I'm going to open this up for discussion with everybody, and I hope that it's a nice and robust discussion. There are a number of highly salient points that were raised here in terms of the assumptions and the biases in terms of publications, how that can skew our understanding of knowledge, the assumptions that underlie those basic experiments, the kind of reification, if you will, the randomized clinical control trial is the ultimate arbiter of truth with a capital T, when sometimes we don't need that, how that interplays. I loved Meg's example in terms of tribalism in this sense, or feeling like all of a sudden I'm the minority, and how does that feel, and how that can impact patient care, both because of the care that you provide, and then the perception that you're not part of them, and you're stuck between a rock and a hard place. And then Amy's examples were beautiful too, in terms of the tribes that we see, if you will. And I know there's some pushback about the whole idea of tribes, but it's really in-group, out-group. And last time we talked about how our brains are hardwired.